The four main points that I hope to leave you with in this presentation is first and foremost the idea that atherosclerosis is a pan-vascular process. Second, that peripheral artery disease is tremendously underappreciated in all of our patients and in society, but that it confers profound cardiovascular morbidity. And that it's extraordinarily important for us to recognize patients who might have peripheral artery disease early, so we may offer them treatment and focus on risk reduction. And finally, that endovascular strategies rival the long-standing surgical paradigm for revascularization in the appropriately indicated patients. So first and foremost, this idea that atherosclerosis is a pan-vascular process. My father was a neurologist who used to say that when there's rust in the basement, there's rust in the attic. So when there are patients who might have peripheral artery disease that afflicts the legs and have symptoms in the legs, we have to be really on the lookout that there may be athero throughout their body that confers a morbidity of stroke and heart attack corresponding to the various loci in which are involved. Peripheral artery disease is tremendously prevalent in contemporary society. As you can see here on this table, it afflicts nearly 9 million Americans, especially in later decades of life, primarily over the age of 70, where 1 in 5 may have peripheral artery disease. Internationally, it now affects more than 200 million across the world, and this represents almost a 25% increase over the prior decade compared with before then. As you can see from this bar graph here, it has a predilection for individuals of Southeast Asian descent, as well as the Western Pacific region, and also in Europe. The risk factors for peripheral artery disease are no mystery to any of us. Smoking really leads the pack, diabetes a close second, hypertension, dyslipidemia. This is what we're familiar with from all of our patients who have coronary artery disease. Some of the symptoms and signs that we expect for patients with peripheral artery disease, if you read the textbook, intermittent claudication is described as a pain or an ache or a fatigue that occurs in the leg with exercise, but is resolved with rest. There was a famous Rose questionnaire that was offered to individuals to see, how often these particular symptoms come up, and really only about 1 in 4 individuals describe these types of characteristics. In advanced cases, individuals might even have rest pain, however. That might be pain or paresthesias in the foot or the toes. This may be worsened with leg elevation and improved with dependency. So you'll often hear of a patient saying they may have pain in their leg or their foot at nighttime and feel the need to dangle it over the edge of the bed. That's how I discriminate it from that forsaken Charlie horse that wakens people in the middle of the night. Different, very different situation, different description. On exam, we expect to see a decreased or an absent pulse, and not to be tremendously pedantic here, but in our haste of a typical 15-minute follow-up office visit, it's often difficult to take a 70 or 80-year-old patient, put him on the table, take a history, take off the socks and shoes, and really feel for the absent or decreased pulse. Often we need a Doppler to really determine this, but I would encourage all of you, if you take one lesson home from this lecture, that it's just so important to identify those particular physical findings. There may be bruise at the carotid, supraclavicular, abdominal, or femoral location. There could be muscle atrophy in really advanced cases of peripheral artery disease, or pale feet when you elevate them, or there may be ruberous if you put them down. And there may be some other chronic signs of ischemia with hair loss, thickening of the nails that are very dystrophic looking, smooth, shiny skin, or cool or pale or cyanotic looking extremity. When we try to establish the differential diagnosis of peripheral artery disease, often this is done by taking a careful history, performing a meticulous physical exam, and then in certain circumstances, non-invasive assessments that I'll elaborate later, or in rare instances, even invasive angiography and other evaluations. Claudication is most often, I think, confused for signs and symptoms of degenerative disc disease. It afflicts people of the same demographic background so often. There may be spinal stenosis, which is also often referred to as pseudo-claudication because so many of the manifestations seem so similar. I do often hear from patients, though, that when they have pseudo-claudication or spinal stenosis, they may feel the need to lean forward and rest their elbows against a shopping cart when they're walking in the grocery store. And this is a little different than claudication. It's often positional and dependent based on gravity and effects on the spine. Other orthopedic pain, hip osteoarthritis, diabetic neuropathy, or deconditioning and muscular strain can also be confused, I think, for peripheral artery disease. When we try to distinguish between these, we have a few weapons in our arsenal for how to determine this. And I've grouped them here as either physiologic assessments or anatomic ones. And we really tend primarily to gravitate towards the physiologic. And this includes segmental pressure measurement. And the Ankle-Brachial Index is one of these types of assessments that I'll come back to in a moment. There's also pulse volume recording, treadmill exercise testing. And then the anatomic delineations can be determined by color-assisted duplex ultrasound or magnetic resonance angiography or CT angiography. So the Ankle-Brachial Index is so incredibly important. And I know that we all learn about this in medical school, and some of us deal with this in our practice, but it's something that's so simple, totally painless for the patient. It's accurate and it's highly reproducible and basically doesn't cost anything. And the clinical utility is that we can diagnose peripheral artery disease, and I hope to convince you that this can be a predictor of major adverse cardiovascular and cerebrovascular events. When looking at the current updates to the peripheral artery disease guidelines in the AHA and ACC, we see that Ankle-Brachial Index receives a recommendation class 1 for patients who have a history or physical exam findings suggestive of PAD. And it also should be reported as abnormal if it's less than or equal to 0.90, borderline if it's between 0.91 and 0.99, normal if it's between 1 and 1.4, or it's non-compressible at above 1.4. And I'll talk about all of those in detail because I think this is such an important determinant. Note here that it is a class 2A recommendation in this guideline for patients who are felt to be at increased risk of PAD, but without the history of physical exam findings. This is something that people ask me about very often. When should I check an ABI? And I think that if they're in a high risk group, elderly, smokers, diabetes, one can consider this. The history and physical exam findings are shown over on the right. We've talked about them, and I hope that this presentation will be available for you to review in greater detail ad hoc. So the Ankle-Brachial Index, not to be pedantic here, because I know we've learned this before, but just to review, is one in which we compare the blood pressure at the ankle and we divide it by the blood pressure in the arm. And what's different than the way that we typically check this in the office is that you use a Doppler to determine where the systolic blood pressure is. Use a Doppler at the brachial artery, use a Doppler at the higher of the two foot pulses, whether that's the dorsalis pedis or posterior tibial. You want the higher of the two. And you compare that for each leg against the higher of the two arm blood pressures, and you construct the ratio. If you think about it, the leg blood pressure should be effectively equal to that in the arm, or maybe a little bit higher. That's why the ABI shown here should be between 0.90, and it should say 1.4 here with the updated guideline. Shown here is a segmental limb pressure. This is how it's done. This is like an ABI done through every locus throughout the legs. You can see it's done starting at the toe with a little tiny blood pressure cuff on the toe, on the forefoot, which is the metatarsal area, at the lower ankle, at the calf, at the lower thigh, and the upper thigh. So these are done from bottom up, and we check the blood pressures compared against the arm. And this helps us to identify the location and severity of PAD, because you can see between which two blood pressure cuffs the pressure steps off or goes down. And this can be an important measure to differentiate between claudication and pseudoclaudication in those patients who are at risk. Also, this can create a continuous wave Doppler performed at the dorsalis pedis and posterior tibial, and we obtain both arm pressures just like in the Ankle-Brachial Index. So using this, and also by constructing a pulse volume recording, it effectively creates almost like a non-invasive arteriogram here. And you can see that in a normal arteriogram, just like if you saw some patient with an arterial line in the radial artery, you expect to see a tall amplitude that's relatively narrow complex with a dicrotic notch in a normal waveform. And similarly, as you check this non-invasively, the greater the disease leading up to that cuff where the PVR is assessed, it tends to broaden the waveform, to lose the dicrotic notch, and to reduce the amplitude of this. So it effectively constructs what we would refer to as a pulsus parvis et tardis in a patient with aortic stenosis, but the inflow resistance is actually from an arterial stenosis proximal to where that blood pressure cuff is found. So this is important. When you look at pulse volume recordings, you look for this particular morphology. Here is a study that shows how also the propagation of the arterial waveform in a pulse volume recording is active. You know, the arteries are muscular and elastic, and they actually help to propel the blood flow down towards the toes. So when you look at a thigh pulse volume recording and a calf pulse volume recording, expect to see augmentation at the calf, and you can see how the amplitude increases at the calf compared to the thigh, whereas somebody who might have disease between the thigh and the calf, a superficial femoral stenosis, for example, shown here in this patient's left leg, will not reduce in that appropriate augmentation. So you might be suspicious that they have some degree of peripheral artery disease when you see that. Segmental blood pressure recordings can have some limitations, though. If somebody has a calcified artery, it can be very, very difficult to compress it to the point of obstruction of the pulse there. Additionally, if somebody has moderate resting peripheral artery disease, it may not really tease out that there's a gradient across the stenosis. You may have to exercise that person to have that gradient be manifest. I often think of it like if you have a garden hose and it has a mild kink in it, you know that the amount of resistance that that kink confers would be worse if you open the spigot at your house all the way versus if you just had a trickle of flow coming through the hose. It's the same physiology in an artery. So when patients walk, a stenosis that at rest isn't really meaningful becomes much, much more meaningful. It also is difficult using pulse volume recordings to determine if there's a stenosis versus if there's an occlusion. There may be collateralization around an occlusion that allows a pulse to get past that point. Moreover, if there are a lot of resistors in sequence, it's difficult to distinguish the implications of any one of them because the pulse and pressure is reduced after the more proximal of them. So it's difficult to tease this apart. And therefore, if there's a lot of inflow disease, something in the aortoiliac segment, it may be difficult to identify if there's something below the inguinal ligament that also is contributing to reduction of perfusion and of flow. Something that's incredibly helpful to use is the graded exercise treadmill test. This is like the bread and butter of what we do in determining if people have peripheral artery disease. It's just like an ETT when you're assessing if someone might have coronary disease and coronary ischemia. There's the standard protocol that's followed. In this case, it's not like a standard Bruce. It's actually just a 2.0 mile per hour, 12% grade. The patient walks at that fixed level and rate for 5 minutes. And what this often can do, there are some other graduated protocols that are less often used that are listed here on this slide. But what this can do is essentially create a functional yardstick whereby you can identify first how far can the patient go and how much encumbrance is there to the blood flow getting down to the ankle over this exertion of effort. This is a picture of a gentleman walking on a treadmill. This is what it looks like. There's a cuff on the arm, cuffs on the ankles, and walking right there under supervision. Something that's very interesting, I used to have an office practice in the Waltham satellite clinic that also had a vascular lab built into it. And very oftentimes there'd be a patient having a peripheral artery assessment through this walking test, and the techs would come over to find me because of course there might be occult coronary disease and angina manifest by the patient when they're walking on a treadmill with ST depression and so on. So I'd often have to sort of jump in and kind of help to read those types of studies. So it can unmask not only the severity of their PAD, but the potential for concomitant coronary disease. And this might be the most strenuous exercise they get under supervision. Here is an example of an individual who was evaluated for lower back pain and buttock discomfort. She was only 36 years old, and clinicians rightfully had been concerned that she might have osteoarthritis or lumbosacral disc disease. And what you see here, if you put on your thinking cap, is that there's a remarkable reduction of amplitude and spreading out and distribution of this pulse volume recording at the thigh. So you might also be concerned that there's aortoiliac inflow disease. This is what it looks like when you see a resting, effectively ankle-brachial index, and then after exercise, which is at the 1 minute mark here, you can see that the blood pressures in both legs drops dramatically compared to the resting blood pressure. So this is a great example of how resting gradients with especially inflow disease may be misleading. So if you just did a resting ankle brachial index on the patient, you may not be quite as concerned as after exercise in these individuals. So this is profound aortoiliac disease, and that patient underwent bilateral kissing iliac stenting with improvement of her symptoms. It was not osteoarthritis. Moving from the physiologic assessments into the anatomic assessments, arterial duplex ultrasound testing is a great way to screen and identify the specific anatomic issues that cause people to have claudication when they are determined to have peripheral artery disease. I don't think this is our go-to test to just say, do they have PAD or not? This is something where we cone in and say, is there disease in the superficial femoral artery, or did the stent that I placed in the superficial femoral artery develop restenosis? This is a targeted assessment that's anatomic. It's entirely risk-free and is relatively inexpensive to do and is not painful for the patient. It allows us to directly visualize what's going on in the vessel. Here's an image of a patient who previously underwent an iliac stent. You can see in the upper left-hand panel how you can actually see the stent in its profile, kind of cut in cross-section, if you will, how it illuminates on the ultrasound imaging and the rendering in the top two panels. You can also see what the flow characteristics look like through that. This is just similar to when we're checking for Doppler interrogating flow in 2 dimensions in an echocardiogram as well. Here's a great image of a patient who underwent a Gore-Tex graft onto the distal portion below the knee of the perineal artery, and you can see the anastomosis there illuminated where it's attached, and you can see a stenosis just proximal to it. So you get tremendous resolution, and it's important for surveillance of bypass grafts to make sure that there aren't the development of anastomotic lesions that might lead to the risk of graft thrombosis over the years. Here is the diagnostic algorithm that we developed in the AHA and ACC peripheral artery disease guideline. And what I want to call your attention to is the idea, first and foremost, at the top of this flow diagram, determining if the history and physical exam suggest peripheral artery disease. And if it does, the Ankle-Brachial Index is really the primary determinant about how you pursue further evaluation. If the patient on the left-hand side shown here has a non-compressible artery, the Ankle-Brachial Index is greater than 1.40, you can then use a toe brachial index. The toe arteries tend to be compressible, and then you can look at a TBI to determine if you think that they have peripheral artery disease. If it's a normal Ankle-Brachial Index, then perhaps you can pursue an exercise ABI to try to tease out if they have PAD, or maybe search for alternative diagnosis. And if they have an abnormal ABI less than or equal to 0.90, you know they've got PAD. And what I think that this diagram also helps to indicate is the first thing you do when you find that the patient has PAD is focus on their global risk factors and risk factor modification, and then consider lifestyle modification and consider an exercise program. And revascularization is considered after all of those have been addressed. And anatomic assessments are really only necessary after you've identified PAD through using the ABI or exercise ABI. Anatomic assessments are really only necessary if you're thinking about a revascularization in these particular patients. This slide here, I think arguably is perhaps the most important point that I want to make in this entire presentation. This I refer to as the tip of the iceberg. Specifically, these were assessments of individuals over the age of 55 who had intermittent claudication. And when you look at the left-hand side of this diagram, the peripheral artery disease outcomes are relatively stable. These people are not necessarily harmed because of like a leg issue. About 75% of them over the course of the ensuing 10 years had stable claudication. Very few had progressive claudication, and even fewer required some type of revascularization or amputation. So I hope I make this point clear. I am an interventional cardiologist. I do peripheral intervention, but the vast majority of individuals we see do not come to need those particular services. However, when you look on the right-hand side of this diagram, the cardiovascular morbidity and mortality of only having intermittent claudication, that confers a 5-year mortality of 30%. So the rust in the basement being present in the attic as well confers a risk primarily of a cardiovascular. 75% of these people have a cardiovascular death, so stroke, MI. And another 20% may have a non-fatal cardiovascular event. So the morbidity just of identifying claudication is so incredibly important for us to determine and quote unquote intervene with medical intervention that I'll come to in a moment. This study here, the REACH registry, was done in 44 countries, almost 9,000 patients. And what this demonstrates is the worse the PAD, the worse the outcome. On the left-hand side of this bar graph, asymptomatic individuals with an abnormal Ankle-Brachial Index had a 2-year event rate composite of MI, stroke, or death of nearly 9%. And as you move towards the right, the worse and worse their PAD was. We're on the far right. That's where they've had a prior lower extremity amputation. You can see within 2 years, the composite MI, stroke, and death rate was over 15%. So this is a profoundly morbid condition. And this idea that athero anywhere means athero everywhere, and the worse you got it in one place, the worse you're going to have it everywhere, I think is one of the key points that I want to make here in this presentation. When you think about it in a global context, the outcomes of PAD are actually worse than they are for breast cancer or Hodgkin's disease, and are just behind colon and rectal cancer and lung cancer. So it's an incredibly morbid and mortal condition. But I think that even as cardiologists, sometimes we will, having conversations with our patients, not really think of this as something that is more sinister than a cancer diagnosis when we talk to them about why we need to reduce their risk factors and what their potential outcomes are. So I think that's an incredibly important point for us all to take home. Interestingly, when we look on a societal level about whether or not people in the United States even know what PAD is, this was a study done by the National PAD Coalition, and they cold called people over the age of 55 and said, do you know what PAD is? and only about a quarter of them knew what it was. When they asked people, however, if they knew what cystic fibrosis was or what ALS was or multiple sclerosis was, let alone high blood pressure, high cholesterol, more people seem to know what CF, ALS, and multiple sclerosis was than knew what PAD was. And this is like way before that ice bucket challenge. So this is just people kind of knowing from hearing through radio or TV what this stuff is. They know about it, not PAD. But when you look at the predilection of those specific disease processes compared to PAD, it is tremendously much lower risk. These are tens of thousands of people who have CF, ALS, or multiple sclerosis, whereas PAD afflicts 9 million people. So once we've identified that individuals have PAD, what do we do to treat them? I think the first and foremost, we should focus on the ounce of prevention being worth a pound of cure. And so specifically what we do is any patient who has PAD, I think, should be referred to a podiatrist to protect the skin of their feet, because if they get an ulcer or skin breakdown, then it leads to gangrene and can ultimately lead to amputation. So keeping them safe is important. An exercise program can help people have fewer symptoms from claudication and is now supported by CMS, so they can be referred to cardiovascular rehab and reduce the risk factors. Then in select cases, pharmacotherapy may help to improve claudication symptoms or revascularization. But most importantly, we focus on modifying the risk factors. The one shown here, smoking cessation, cholesterol reduction, which should involve a high dose of a high potency statin, just like it does for cardiovascular disease. And then treatment of their diabetes in a tailored fashion, antihypertensive therapy targeting a blood pressure of less than 130/80, and antiplatelet therapy. While there are some data that suggest that maybe clopidogrel is more effective than aspirin, like in the Capri trial, I think that keeping them on a single antiplatelet agent can be helpful. Just with an 81 milligram aspirin a day, that's adequate. And those all receive a class 1 indication in the new AHA-ACC guideline for PAD. Home walking programs demonstrated here by Mary McDermott and her group at Northwestern demonstrate that even in an unsupervised fashion, people who are encouraged and counseled how to do a home exercise program can have improvement in many of the parameters that assess their quality of life and their functional capability with claudication. And this should be a first step I would submit in every patient unless they have critical limb ischemia or the urgent need for revascularization to save the limb. Cilostazol, shown here, can also improve outcomes. Pentoxifylline is no longer recommended. It's not felt to be effective. But cilostazol can improve the pain-free walking distance. When you look at what it actually amounts to, the pain-free, so before claudication onset walking distance improves by, say, about 40 to 50 meters if someone's taking cilostazol. And similar for the maximal walking distance, how far can they go until they need to sit down on that park bench or somewhere in the mall, is improved also by about 50 meters or so. So these are modest improvements, but in an elderly, somewhat infirm patient, that may be all that makes a difference in their quality of life. They can get around, they can do what they need to do. So you have to participate in shared decision-making with these patients. Cilostazol should not be used in any patient with a prior history of congestive heart failure, because that has a black box warning and can lead to circulatory collapse in those individuals. The indications for revascularization, changing gears now to think about in whom this is appropriately selected. First and foremost is critical limb ischemia. We learned in medical school the 5 Ps, including rest pain and pulselessness. Also, patients who have ulcers, gangrene, or necrosis should be revascularized to save the limb. A little bit more subjectively, then we move on to a patient who reports disabling claudication. I think that sort of is a subjective determination there, and same for quality of life. But as we see that our ability to safely and more durably revascularize these patients, we have a change in the kind of margin or calculus, if you will, as to in whom we wish to offer these types of procedures. Some randomized controlled trials have looked at exercise programs versus revascularization to determine which is the more effective method for treating patients like this. In the CLEVER randomized controlled trial, which received a tremendous amount of press, there was the determination or a breakdown of only 119 patients who were randomized in this trial to receive either optimal medical care alone, a supervised exercise program, stenting, not with supervised exercise, or supervised exercise and stenting, but the study ultimately closed and wasn't able to enroll enough people in that particular arm, so did not consider stenting plus supervised exercise. And what they found was that the change in peak walking time from baseline to 6 months improved most in individuals with a supervised exercise program, even if they had critical aortic stenosis, not aortic, aoroiliac stenosis, when compared with stenting and optimal medical care. And so it's interesting to think about this, but exercise can be highly effective even with that fixed vascular stenosis. But what was not shown in this trial was what happens if you do both a stent and exercise in these individuals. So that was the key that was the key finding that was determined from the CLEVER trial, but it really left that one missing question of what do you do if you have combined therapies. So the ERASE trial that was published just 5 years ago did look at that specific question, and it did include individuals both with aortoiliac and femoropopliteal disease. It was a larger study that included over 212 people, and it also included stenting for the most part, but also supervised exercise in every patient and supervised exercise alone in others. So they were randomized 1-to-1 to these two arms of the study. And basically the supervised exercise program was incredibly rigorous. You can see here 2 to 3 times a week for 3 months or so. And what they found was at their follow-up segments, and this is a bit of a busy slide here, but if you look group by group, what you can see is that at baseline, the patients were equivalent. At 1 month, if you look first at their maximum walking distance, those who got an endovascular treatment versus just the supervised exercise alone, at 1 month, they were just categorically different. People could walk for 1,000 meters if they got a stent and exercise, whereas they could only walk about half that if they just had supervised exercise. But at the end of a year, the gap actually closed quite considerably, still better with the stent and with exercise, 1,200 meters, if you will, at the end of a year, compared with about 1,000 meters for supervised exercise, but it narrowed. So you can see that there can be quicker recovery of functional capability with stenting adjunctive to supervised exercise, but supervised exercise does pretty darn well as well. So in our patients and in our practice, we often will start now that CMS has approved supervised exercise, with that strategy, see how they can do, and if patients continue to be encumbered by claudication, then they can be considered for revascularization at that point. When we talk about revascularization, stents tend to do better than angioplasty in the aortoiliac segment. You can see the worse off the PAD, the worse off the patency of the vessel, but stents tend to have better long-term patency than does angioplasty alone. Surgical disease has long been touted as the gold standard and the most durable way to treat patients with aortoiliac or femoropopliteal or below-the-knee disease, but I think that our strategies and our paradigm has really evolved over the past 2 decades. And what remains a constant in the background is the risk that is conferred to these patients from open surgeries because of the concomitant disease that they have throughout the aortoiliac segments and throughout the cerebrovascular and cardiovascular segments as well. The operative mortality can be as high as over 3%. The systemic morbidity can be over 8% for these individuals, and it can take several weeks for full recovery, whereas with endovascular approach, the risk and recovery times are much better. In the past, the TASC Consortium, which was a transatlantic society of cardiovascular and vascular specialists, had determined that the more complex the disease, the less likely this was to respond well to endovascular approaches as opposed to surgical approaches. This is a paradigm that has long since been dismissed, and our surgical colleagues, who are now very aptly and adeptly trained in endovascular intervention, are also primarily using endovascular approaches now for these patients. Here's a candidate example of a patient who had a TASC-D lesion. You can see that the right common iliac in this patient is totally occluded with an enormous lumbar collateral reperfusing downstream to the external iliac and distal common iliac there on the right-hand side. And in these types of patients, we now have techniques and technologies that can permit us to place a stent at that segment crossing the chronic total occlusion and can get a very, very adequate and excellent result here without the need for surgery in these particular patients. So it's touted that endovascular therapy certainly is less invasive than an open surgical approach, that there can be it can be safer with fewer adverse effects. There can be similar efficacy compared to surgery and shorter length of hospital stay, faster return to work, and it can potentially be more cost effective as well. When we think about disease that extends further down below the level of the groin, things change. The topography totally changes, the outcomes change. This has long been viewed as the Achilles heel of the vascular specialist because it's difficult to maintain patency no matter what you choose to do to treat this. I think in large part this is because that there are so many mechanical forces that afflict the superficial femoral artery. There's the muscles of the leg that are extending and contracting the vessel. There's torsion on the vessel as you rotate the leg. There's compression behind the knee and a lot of flexion there. So if you look at an angiogram of a knee that's flexed, you can see that in the adductor canal, the distal superficial femoral artery into the popliteal artery is absolutely tortured. So you can think that if you did a bypass graft or if you put a stent in a segment like this, it's going to be subjected to all of these extrinsic forces over time, and it may affect its long-term durability. 5-year patency rates correspondingly are not as good in this segment as they are in the aortoiliac segment. But again, comparing surgical complications to those of endovascular therapy, there are a significant number that weigh against us when we think about addressing these with surgery. And so that is often reserved for specific cases, especially very advanced claudication or critical limb ischemia. The Basel trial that was published in 2005 looked at amputation-free survival on an intention to treat analysis of balloon angioplasty versus bypass surgery. The dark blue line is the balloon angioplasty, the light blue line is the bypass surgery. And effectively, they were looking at amputation-free survival at 3 years. And what was identified was that specifically, there was no difference at 3-year amputation-free survival comparing each of these index strategies. When you drill down on the details, even though there was significant crossover between the two groups, angioplasty patients did tend to need to cross over to surgery more often. And you can see there down under further interventions that about 21 of the 237 individuals who started with angioplasty needed surgery later. These were actually included individuals who were enrolled with critical limb ischemia and a disease extending effectively from the groin down to below the knee. So with angioplasty alone, perhaps that's not tremendously surprising. But if you look in the surgical group, there was a higher rate of wound infection, chest infection, and so on. So the morbidity that's conferred in these particular individuals who undergo a surgical approach is different than that for the angioplasty. So that was a very seminal study that was done now 15 years ago, and certainly techniques and technologies have evolved since then. This study done by Martin Schillinger's group in Germany demonstrated that stents in the superficial femoral artery could yield more durable results than balloon angioplasty alone. This was back in the day before any drug-eluting therapies were available. This is in 2006. And the maximal walking distance was similarly better with stents than it was with balloon angioplasty alone for superficial femoral artery disease. So a theme sort of moving towards better acute results with stent and perhaps even better durable results, but it depends always, I think, on lesion complexity and location of lesion and more. Stents are not a panacea. You can see here an image of a stent that was flexed to the point that it fractured at multiple locations in the adductor canal. And here is a patient of my own who was a letter carrier who on one side underwent treatment with a self-expanding stent here, and you can see it's just torqued beyond recognition. This vessel was ultimately totally occluded with a fracturing of the stent at multiple locations. But in his opposite leg, where I used a different woven stent platform, you can see that that type of stent with a totally different configuration had better durability in the same patient and same, one would presume, extrinsic condition set. So there may be hope on the horizon of using different stent technologies with greater resistance to fracture and perhaps greater durability and patency rates. One passion of mine is to try to approach peripheral artery disease interventions from transradial access. We know in cardiovascular interventions that transradial access confers lower risk of bleeding and has fewer vascular complications associated with it. And in acute coronary syndromes may even reduce morbidity and mortality. So why not try to convey these same potential benefits to individuals with peripheral artery disease? In Boston, we often will say if there's a difficult course to navigate, you can't get that from here. So when we're talking about peripheral artery disease, you have to be very careful that the equipment that you have available can reach those long distances to get from the wrist all the way down. This is a patient of mine who had a disease at the outlet of his endovascular aortic aneurysm repair graft in the right leg, and also had superficial femoral artery disease down a little bit further. It's very difficult to get a catheter from the left groin up and over the acute angulation of the two limbs of the graft to get down to fix that common iliac lesion down below where the stent graft ends. So we elected to do this from left transradial access in the hope that we could also reach down to a superficial femoral artery. Here's an angiogram of his upper extremity, then the catheter getting down into his right common iliac artery for the angioplasty, and then one all the way down that reached all the way down to his superficial femoral artery where we performed balloon angioplasty with a great outcome. The final subject I wanted to discuss as we kind of have marched from the heart downwards towards the toes is the treatment of infrainguinal and then ultimately infrapopliteal disease. Seen here when we talk in conclusion about infrainguinal disease, same advantages that I described for aortoiliac disease compared with surgical approach, lower risk of wound infection, low mortality rates, potential cost advantage, repeatable and preferred by patients. But the durability is always the question when we talk about the superficial femoral artery. When we talk about critical limb ischemia and below the knee interventions shown here on the right-hand side, I'm sorry, you guys are probably just eating breakfast around now. Infrapopliteal disease can lead through endovascular treatment to improvements in wound healing. Shown here is the same patient 6 months later after she underwent a stent in the SFA and a perineal artery angioplasty, and that was a durable outcome for this particular patient. This was a study conducted by Jerry Doros and my mentor, Michael Jeff, that showed that the prevention of limb amputation can be profoundly enhanced by angioplasty and endovascular treatment for critical limb ischemia. You can follow hashtag CLI Fighters on Twitter also for further information and the emerging envelope of therapy that these individuals are pursuing as well. What we find in the studies of treatment of critical limb ischemia, however, is that durable patency is always an issue. It is difficult to keep arteries below the knee open, but if you provide enough flow for long enough, often the wound can heal, and it then prevents the development of recurrent ulceration. So even if the primary patency rates are as low as 22% in one of these studies in this meta-analysis, the 12-month limb salvage may be as high as 90%. So just getting enough flow down there so that the skin heals and the nutrients get down to those ulcers may be all that's needed. You may not need to have indefinite patency of these vessels, so you take what you can get. There is a randomized controlled study that has been sponsored by the NHLBI called the BEST CLI study. It's a $25 million study that is looking at whether or not surgery and endovascular therapy, which of the two will be preferred for patients. This requires a multidisciplinary vascular team to see and evaluate every patient and determine which is the best treatment strategy for that patient. And the primary endpoint is major adverse limb events, male-free survival. And we are all eagerly awaiting the outcome of the study that continues to enroll. When we think about the tools at our disposal for revascularization, there are many arrows in our quiver. There are many patients who come to me and say, "Doc, can't you just use the roto-rooter?" And honestly, any one of these strategies confers some degree of injury to the vessel wall, and that is what provokes restenosis. And so no matter how you deal with the lesion, whether it is through atherectomy that carves some of the plaque out either rotationally or orbitally, one that cuts with a pie cutter, that is directional atherectomy, whether you use laser to ablate the plaque, or whether you stretch it with a balloon, or whether you insert a stent, all of these confer some injury. We used to use cryoplasty, we don't anymore, in the idea that if you froze the vessel wall, it might induce apoptosis and reduce the risk of restenosis. That never bore fruit to reduce restenosis. And effectively, none of these had provided support for long-term durability better than one another until the advent of drug-eluting stents and drug-coated balloons. And I want to spend the remaining few minutes just talking about those. In the drug-eluting stent trial, looking at the Zilver paclitaxel-eluting stent, we found that even 5 years later, the use of Zilver PTX stents compared to bare metal stents had greater durable patency in this particular trial, shown in this diagram here by Mike Dake and company. And drug-coated balloons had offered tremendous promise to reduce restenosis by effectively painting the wall of the vessel with paclitaxel, which would then set up a secondary resonance in the vessel wall and engender a restenosis reduction over the course of months. We thought that this would be better to use, especially in no stent zones or maybe in the superficial femoral artery where there are so many extrinsic forces, as we discussed, and maybe even for treatment of in-stent restenosis, and may have implications in terms of the duration of dual antiplatelet therapy that would be required. What we found in the clinical trials was indeed in the Levant 2 trial, this is one particular drug-coated balloon study that involved improvement in outcomes at 1 year's time in terms of the primary patency. and freedom from their safety endpoint compared with standard balloon angioplasty. And then in the IMPACT SFA trial, also at 2 years, they had data that suggested better patency in the red curve above balloon angioplasty alone, in the blue curve below with the drug-coated balloon. About a year ago, Katsanos and company in Greece conducted a meta-analysis of all of the clinical trials that looked at peripheral drug-eluting therapies compared with conventional therapies. And in their combined assessment of all of these clinical trials, they found a concerning signal towards a higher rate of death in patients treated with paclitaxel-eluting therapies. This immediately sparked profound debate in the peripheral vascular community and beyond, because as you may imagine, these technologies involve a very small amount of paclitaxel, vanishingly small compared with the amount that is systemically administered for chemotherapy regimen. And it is delivered only locally to the blood vessel. And how could there be mechanistic plausibility to this increasing the death rate? There were many methodologic challenges to this analysis, and the FDA convened a group of experts in peripheral vascular disease to examine the data, and they did conclude that there was indeed a late mortality signal, but that these findings should be interpreted with caution because there were so many limitations to the way that the meta-analysis was conducted. First, there were wide confidence intervals. It ultimately involved a small sample size, and there were pooling of studies that were never meant to be combined using various paclitaxel-coated devices that had different doses, different release kinetics, and the pathophysiologic mechanism really was just unclear. And they ultimately concluded that additional clinical study data would be needed. Eric Sisemski and Bobby Ye at Beth Israel Deaconess conducted a CMS database review of over 16,000 patients who were treated for peripheral artery disease with either non-drug or drug-eluting therapies. And in these curves, the probability of death actually looked to be lower in those treated with drug-eluting therapies, but they were not statistically different one to the other. So in looking at the entire database of individuals with follow-up data in the United States, we don't see that the signal bears true. So this is still a raging debate, I would say, within the interventional community. But the FDA's recommendations left with us are that we should carefully monitor any patient treated with paclitaxel, that we should talk about the risk with them up front and participate in shared decision-making, especially given that there's unknowns, and that we should consider whether or not specific lesion subsets might warrant a consideration of just going with a conventional non-drug-eluting therapy. A short focal stenosis may be less inclined to restenose, so maybe that one should be treated with a non-drug-eluting therapy, whereas more extensive and complex disease could consider for drug-eluting therapies. And the recommendations also include, of course, to focus on guideline-directed medical therapy and continued reporting to the FDA for further follow-up. The guidelines that we developed about revascularization are that if there's lifestyle-limiting claudication, first of all, that's defined by the patient rather than by any test. And this may be something where, example, in my letter-carrying individual might be different for that individual than for my 80 or 90-year-old patient who lives in the North End and just wants to walk to the corner market. So we have to determine whether or not revascularization is appropriate. It's only one component of a customized care plan that involves guideline-directed medical therapy, exercise, and podiatric care to minimize tissue loss. The role for revascularization should be focused on patient preferences and goals of care, the likelihood of durability of benefit, and shared decision-making ultimately. And it's felt that it's reasonable, a 2A recommendation for patients with lifestyle-limiting claudication with an inadequate response to guideline-directed medical therapy. The use of endovascular treatment in those patients does receive a Class 1 recommendation for patients who have lifestyle-limiting claudication and a significant, hemodynamically significant aortoiliac lesion. When you look at a surgical revascularization, this can also be appropriate in these individuals, but it should be only with autogenous vein to the popliteal artery, not with prosthetic graft material. So in summary, when we're thinking about how we choose to treat our patients with peripheral artery disease, we can hierarchically think about this as, first of all, preventing their death, focusing on guideline-directed medical therapy. Secondly, we think about reducing their symptoms, and that should be heralded first by an exercise program, consideration of pharmacotherapy, and in select individuals considered catheter-based interventions or reconstructive surgeries. And then finally, in those with critical limb ischemia, thinking about how best to save their limbs, Primarily, I would submit through catheter-based interventions or, when necessary, reconstructive surgery. I don't want to leave you with the idea that interventional therapies for PAD is a panacea. Shown here is some of the outcomes that we can see with profound atheroembolism that can be life-threatening. And on the left-hand panel, you can see some scraps of athero that come back through our catheter system onto our drape as we do these types of procedures. So I think we always have to tread with care as we approach patients who might have hostile atherosclerotic disease. So I hope I've left you with these 4 key points addressed: that first and foremost, atherosclerosis is a pan-vascular process. When there is rust in the basement, there is almost assuredly rust in the attic. That peripheral artery disease is underappreciated, but it confers profound cardiovascular morbidity and mortality. And I would submit it's incumbent on us as care providers to inform our community to be on the lookout for this. When there's just a pain in the leg, there may actually be a risk of stroke and heart attack down the road. Early recognition of these individuals is paramount because we can focus on their risk reduction to help to save lives. And in specific, uniquely qualified individuals, endovascular strategies may rival the longstanding surgical paradigm for revascularization. Thank you so much for your attention.